Thank you very much for joining us today for our 7th out of 8 webinars in our Observatory webinar series on the COVID-19 response. Actually, I already have some good news. There will be a 9th bonus seminar. I'll talk about that a little bit later. Today we have a very important topic, which is the COVID-19 responses in countries with social insurance, but we are focusing on the role of primary care, which is of course not exclusive to social health insurance. The response of primary care to the COVID-19 pandemic has received much less attention than hospitals and their struggle to provide sufficient intensive care beds. And actually, primary care doctors and nurses have played a central role in addressing the pandemic by diverting patients away from hospital, and by doing so, relieving hospitals. And in some countries that worked better than in others. Also, primary care doctors and nurses have played an important role in maintaining essential services during the first and the second wave that we are currently in. And they have been quite innovative in developing new capacities and new remote consultation facilities. So I think in this seminar, we will want to learn about what new services were introduced and how the GP role and the primary care role has changed, maybe also comparing the first with the second wave. What flexibility and regulatory support was necessary to adapt to the crisis. We will talk about what can be learned and retained for future crises and the development of primary care, and what lessons can we learn for strengthening health system resilience. My name is Ewald Ginneken from the Observatory on Health Systems and Policies, and I will be moderating this session. I will now take you briefly through the program and our speakers. We will first start with a short presentation from my Observatory colleague Erica Richardson, who will provide an overview of the Health System Response Monitor, what we call HSRM, on which this series is inspired, and she will tell you where to find it, how to use it, and what to expect to see there. Then we will have a keynote from Andrea Schmidt, who is the Deputy Head of the Department of Health Economics and Health Systems Analysis and Senior Policy Researcher at the Austrian Public Health Institute. Some of us know it rather as Gesundheit Österreich. And Andrea is also leading a paper about the COVID-19 response in social insurance countries, which will appear later in a special issue of health policy that the European Observatory is presenting. And Andrea will provide an overview in some of the countries and give some food for thought that our two spotlight country speakers will reflect on, because after Andrea, we will move to François Schellevis. And François started his career practicing a general practitioner in the Netherlands after gradually moving more into academia and having a scientific career. Until his retirement, François worked at the NIVEL, that's the Netherlands Institute for Health Service Research, and we all know a real knowledge broker in terms of primary care. And he was a professor of general practice at the Amsterdam University Medical Center. He will provide us with some reflections from the Netherlands and also with some lessons. So we are really looking forward to hearing from him. The next is Pia Vracko from Slovenia. She is an MD, an economist, a researcher, and a senior advisor on health systems and policy at the National Institute of Public Health in Slovenia. Her work focuses on health system strengthening, and among which strategic development of primary health care and also public health. She is also a member of the advisory board on the COVID-19 response to the Minister of Health in Slovenia. And actually from 2018 to 19, Pia served as a state secretary at the Ministry of Health, responsible for primary healthcare and public health. So she seems to be the right person to ask reflection of, and she will tell us about the situation in Slovenia and hopefully also some lessons coming out of Slovenia. Erica will monitor our chat box. You can ask your questions there for the full duration of our seminar, and we will get back to them at the end. So now we will go to Erica. Erica, the floor is yours.
Thank you very much. Welcome, everybody. I just wanted to take 2 minutes to quickly talk you through the HSRM. First thing to say is that the COVID-19 Health System Response Monitor is a collaboration, and it's a collaboration between the World Health Organization Regional Office for Europe, the European Commission, and the European Observatory on Health Systems and Policies. And the aim is that it should organize and share information in 4 key areas. Firstly, it collects, checks, organizes, and updates the country information to capture what country health systems are doing to tackle COVID-19. But then it also supports comparisons between countries across a range of topics, with you as the user defining which countries and which topics you wish to compare. It also offers links to the most reliable and timely COVID-19 data. And what's very much the basis for this series of webinars is that it also provides analysis of key themes that cut across countries. So these are the snapshots of different policy responses and setting these initiatives into context. It's very easy to find. It's www.covid19healthsystem, all one word, .org. And I think you should all go and check it out if you haven't already, but after the webinar. Okay, so to focus in on the cross-cutting analysis, this section pulls out the sort of narrative threads, the things that are interesting, things that are topical, the things that are important. Now, these questions are often posed by countries or by WHO or by the European Commission. But the aim is for us to, but it's also the editors themselves spot these emerging issues and pick up on trends and patterns as we're sort of bringing the information all together. The aim is for us to give examples and good practices and links to key documents in countries. And these cross-cutting analyses are updated as policy and practice, and indeed the pandemic evolves. Okay, so thank you very much for your time. I'm going to keep it brief, so we've got plenty of time for discussion. Eva, I'm going to hand the floor back to you.
Thank you very much, Erica. Maybe also worth mentioning that we also published a EuroHealth that was based on the HSRM. And I think that maybe, Erica, you can provide a link in the chat box to this special issue, which contains a lot of comparative small articles inspired by our monitor. So now we would like to start with our keynote speaker. So I invite Andrea to take the floor. Andrea, go ahead.
Thank you for inviting me to this webinar and to talk to you today about the role of primary care. I hope you can see my slides. And before I start, I would like to mention briefly that some thanks to some people who have helped prepare this presentation, in particular Juliane Winkelmann, Sarah Burgmann, Matthias Wismar, and Pia Ratschko, and also the contributors of the study that I'm going to present that you have listed also here in this first slide. What can you expect from this talk? I'm going to give you insights into the role of primary care, in particular the role of general practitioners during the pandemic in 8 selected EU countries. And I'm going to try answer 2 main questions. How have GPs contributed to the organization of pandemic responses, and how were GPs compensated during the crisis? I will conclude with some food for thought on the potential role of primary care in future pandemics. And in this map, you can see already a first glimpse of the countries that will be covered. Let me start by setting the scene with a graph. In this graph, unfortunately, we do not have the data for all the countries covered, but I think it's still a nice overview. In this graph, we can see on the vertical axis on the left side, the share of overall COVID-19 patients that were hospitalized in the countries that we're going to talk about today. And on the horizontal axis, you see the time line. So what is most striking in this graph is, for example, that in France, the share of hospitalized patients was very high at the beginning of the pandemic, in the first wave, and it slowly went down. So that already gives us a little bit of an indication of the role of the ambulatory care sector over time and how it has changed in the example of France, and how primary care has taken over some of the responsibilities from the hospital sector in that country, for example. In other countries, there's a similar pattern, but much less pronounced. Of course, there are other factors that come into play here, such as testing capacities, etc. But this is just one of the indications of how the ambulatory care sector has contributed, and the primary care sector is included. Now let me move on to the comparative analysis. I'm going to talk about Austria, Belgium, France, Germany, Luxembourg, the Netherlands, Slovenia, and Switzerland, and how policy responses were characterized. The data were collected in the Health System Response Monitor that was presented by Erica and was complemented by a review of additional materials. The period covered was March to November. Now, the first question, how have GPs actually contributed to the organization of pandemic responses? In this table, you see on the left side the countries covered, and in the first column, you see what has been the role of GPs as a first contact point for COVID-19 patients. And we see some differences. So in Belgium and Germany, but also the Netherlands, as well as Slovenia, those are the countries with the green sign, the GPs have had a very important role as a first point of contact and in some of these countries also for testing and monitoring. In addition, two countries, particularly Slovenia and Luxembourg, had a focus on special outpatient clinics, outpatient care centers. In Luxembourg, for example, out of our offices were transformed to advanced care centers in order to channel patients and keep them out of GP offices as well as out of emergency departments. However, there are three countries in our sample that did not foresee a specific role for GPs, and these are Austria, France, and Switzerland. But they have learned a little bit throughout the pandemic on how to involve GPs a bit more. Now, what about contact tracing? Another important part of preventing infection. So here we see a much more diverse picture in this second column. And we find that only in Belgium and in France, GPs actually had an important role, whereas in the other countries, it's a mix of National Institute of Public Health, local public health offices, and other public authorities, as well as in France, the social health insurance funds. I'm now going to show you two good practice examples from our analysis. The first one refers to Germany and the state of Schleswig-Holstein, which set up an outpatient monitoring system where ambulatory physicians and public health authorities collaborated intensively with the aim of detecting disease complications early and ultimately reduce hospital admissions. Now, how did that work? The doctors contacted infected persons that had been isolated at home in order to assess their health status. And in turn, the public health offices were able to focus on contact tracing and arranging the isolation. The second good practice example refers to Belgium, the platform SafeLink, which is an online platform, and it allows GPs to monitor non-hospitalized COVID-19 patients. How does that work? Again, twice a day, registered patients receive an SMS or fill out an online questionnaire on different biological parameters, and this leads to a dashboard for GPs, and they have an overview of all their patients. And based on that, an algorithm establishes or assesses whether the state of the respective patient is still stable or whether it is moving already towards a critical health. Now, the second question that we wanted to discuss was how were GPs actually compensated during the crisis in terms of financial terms. First, it's important to say that GPs have seen a significant reduction of physical contacts during the pandemic. And in the countries that we've analyzed, GPs are usually compensated on a fee-for-service basis, at least to a large extent. And of course, this loss of physical contact has then also meant a significant loss of income. In addition, they had to face higher costs for protective equipment and for treating and monitoring COVID-19 patients or suspected patients. Now, at global level, you can see on the right that in many countries there has been a significant reduction And in the US, it was even estimated that there was a loss of $15 billion for primary care practices alone. Now, one way to compensate for these losses were teleconsultations that were actually where the conditions for entitlement and reimbursement were eased substantially in France, in Belgium, but also in Germany and Slovenia. In Germany, for example, we saw an unbureaucratic rollout and a more than 11-fold increase in teleconsultations. And also in Slovenia, we will hear then later about the success of this initiative. In other countries like Switzerland, it remained to doctors and hospitals' discretion whether or not to offer these. Now, the specific rules for compensation were quite diverse. So in 3 countries, we saw that I'm not going to go through all the details of this table, so I'm sorry about all the text. I will try to summarize it for you. So what were the rules for compensation of lost income of self-employed physicians in the countries that we analyzed in primary care? In 3 countries, namely in Austria, Belgium, and Switzerland, we saw that self-employed physicians were treated like other businesses, and this was financed from the state budget in terms of the compensation that they received. In the other countries that we saw, there were special rules developed. So if you look at Germany, the extra payments were made if the loss exceeded 10% compared to the previous year. In Luxembourg, it was rather a one-time payment. So, and these payments were covered by the Social Health Insurance Fund, except in the case of Slovenia, where it was also covered by the state budget. Controversies sometimes arose because of the compensations for costs for protective equipment. Now, I've already answered these questions in this very short overview, and I would like to sum up the results. So we've seen that in some countries, the GPs were important gatekeepers. They collaborated with local authorities and made use of ICTs, and they contributed to shielding hospitals from inflows with COVID-19 patients. In other countries, the role of GPs was overlooked, and these are slowly catching up in the second wave. To compensate for income losses, we saw some innovative approaches like teleconsultation boosters, but heterogeneity in terms of financial mechanisms. Now, the different roles of primary care can be summarized in this graph, where you can see that in the blue bubbles, essential care provision had to be maintained. At the same time, hospital admissions had to be avoided, and care for people with infections had to be provided. Also, in the green bubbles, you can see that protection measures had to be taken for the physicians themselves, but also for the patients and for the employees. And finally, primary care as a first contact point was also important in terms of avoiding collateral damage and protecting vulnerable groups or even reaching out. I've already reached the third part of my presentation. I would like to end with some food for thought in 3 more slides. First, an ounce of protection is worth a pound of cure. I would strongly like to argue that strong primary care systems will increase the resilience of our healthcare systems in future crises. We've seen that in some countries, GPs were a lost resource, and that in others, they were a source of potential success in managing the pandemic. So we need to move towards a holistic, integrated approach. And that could happen, for example, by involving GPs more in the creation of nationally coordinated response plans, but also in preparing adequate health information systems. And communication is a crucial factor, of course, also in coordinating these responses. The second conclusion, it's not all about cure, it's about care. What do we mean? We've seen that there have been significant drops in the contacts, in the physical contacts of GPs with their patients during the crisis. And only a few countries like France, they actively reached out to vulnerable groups in so-called prevention consultations to actually make them come back to the doctor's office. Sufficient PPE is the necessary precondition to act on this front line. So the protective equipment needs to be secured in these cases. And but the question remains how the drop in care for chronically ill and for care for people with mental health problems will be compensated in the future. I would like to quote here the European Forum for Primary Care. primary care providers usually know which of their patients are most vulnerable. We must get actively in touch with them. We need to strengthen our patient-centered approach, improving the ability of people to self-manage their chronic conditions, but without asking too much of them. The third conclusion refers to the future. The show must go on. We've seen that GPs have had income losses and they received at the provider level financial compensation. However, at the system level, we need to think also, how can we ensure sustainable financing in social health insurance countries and beyond as a precondition for strong primary care and strong ambulatory care? Because we've seen in previous crises that there is a potential for retrenchment, and that will lead to inequalities in the access to primary care. These are the references that I've referred to in this presentation. And I would like to thank you for your attention, and I look forward to our discussion. Thank you.
Thank you very much, Andrea. It's quite striking the large differences between the countries in the role of primary care. If you have any questions for Andrea about her presentation, please put them in our chat box. Now we will move to Francois and the Netherlands. I'm very curious to hear more about the learning and the changes over time in the Netherlands, in the Dutch response to COVID-19 in primary care. So, Francois, the floor is yours.
Okay, thank you very much, Ewout, and good afternoon, everybody. And I am happy to contribute to this webinar by giving some more details about the situation in the Netherlands regarding the COVID pandemic. And I will start with some impressions on the first wave and the role of GPs there. In the care for COVID patients, GPs really had a challenge in diagnosing patients because there was a very limited test capacity at that time. And a lot of patients were just diagnosed without really being tested. So they had to rely on symptoms. And by that time, in, let's say, March and early April, the symptomatology was not very clear yet. It was very variable, and especially not only respiratory tract related symptoms were sometimes difficult to diagnose. GPs continued as they used to do home visits also to COVID patients, of course, with personal protection. And once diagnosed, most patients were followed up daily by telephone contacts. So the GP called the patient every day at least once to follow up the health status of the patient and, if necessary, to see whether admission to a hospital or referral to a specialist was needed. So a lot of people just stayed at home, and hospitalization took only place on indication. In a few regions, or in a number of regions, also a kind of what I called care hotels were established. These were especially meant for patients who either did not want to be admitted to a hospital because they were too frail and probably would not survive any hospital admission, or for patients who were not that severely ill but who lived at home and were dependent on home care, but the home care was not sufficient anymore. Regarding the care for non-COVID patients, as Andrea already mentioned, there was a dramatic decrease in the consultations and in the home visits in the regular care, let's say. Also, chronic disease management programs and cancer screening programs, which were carried out by GPs, were suspended for a certain period. And you can see that as a kind of collateral damage of the pandemic. The practice had to be rearranged, waiting rooms and walking routes in the practice premises to avoid that people could be contaminated. And I think what is very special for the Netherlands is that the Dutch College of GPs issued a kind of guideline to counsel with elderly and vulnerable patients about the possibility that they could contract a COVID infection, and if so, whether they would really want to be hospitalized and even to be admitted to the intensive care unit. And I think that is a very specific Dutch approach to raise awareness already before people get ill, whether how they want to be managed. Another characteristic of the first wave was, as Andrea already mentioned also, a big increase in video calls and consultations by GPs. These were already used, but on a very limited scale. And this was really, it got a real boost. For the COVID patients in daycare and in out-of-hours care, separate facilities, separate routes were created. And that was usually regionally organized. So by a number of practices who, to avoid that COVID patients would enter in the regular practices. And the financial compensation, which Andrea already mentioned also, was mainly a temporary increase of the capitation fee with 10 euros and some additional refunds for the extra measures and the protective materials, for example, and extra costs. That was really the situation in the first wave. During the second wave, which we are still in the Netherlands, we see that a lot of lessons were learned from the first wave. There is really now a sufficient test capacity, especially delivered by public health services, and GP care is now only really used for people who are ill. So when people just have mild symptoms, they go to be tested and they only contact their GP if they are in need for healthcare. You see that the practices are much better prepared, and there was now a flexible conversion after summer to organize the COVID-19 care again according to the first wave. And there is much less decrease in the care for non-COVID patients. In a number of places, we see a more close collaboration with hospitals, for example, where GPs offer hospitals to supervise recovery at home. So when people are dismissed from a hospital but still need oxygen, for example, GPs offer their services to supervise the recovery of these patients. A real challenge a few weeks ago was to organize the influenza vaccination campaign, which is done every year by GPs, but now in COVID-19 circumstances, and to avoid, of course, contamination and people get infected. And maybe I think that's already a good rehearsal for the COVID-19 vaccination, which will hopefully come up in the coming months, because GPs will again then have an important role for selecting patients who are to be vaccinated. And another lesson which was learned is that GPs will undoubtedly continue the use of technology, especially the video calls, the email consultations, the telephone calls, especially in follow-up care. So not really for, let's say, a first contact, but when people are to be followed up, the technology will be used much more, is the expectation of a lot of GPs. So this was a kind of, well, a number of impressions from the Dutch general practices, and I give back the floor to Ewout. Thank you.
To me, it's a very typically Dutch approach, very rational. I'm sure there will be questions later about it. I have a bunch for you, so I hope.
Okay.
But let's move now to Slovenia, also a country which is known for its quite strong primary care system. And so maybe Pia, enlighten us and tell us whether your approach was similar to the Dutch or whether it was really different. The floor is yours.
Good morning and good afternoon from Slovenia. So primary healthcare in Slovenia is organized as a dense network of community health centers complemented by concessionaire private clinics. At the photo, you can see one of such community health centers in town Kamnik, where a broad array of primary care services are delivered by multiple teams of family medicine, pediatrics, gynecology, dentist, and emergency care, together with basic laboratory and imaging diagnostics and most frequently needed therapeutic services. In Slovenia, primary care serves as the first contact with the healthcare and offers care for most frequent health conditions at one location, close to where people live. As such, it plays a vital role in COVID-19 response, both in contributing to slowing the spread of the virus through testing and providing information to patients, and in managing patients with mild or moderate COVID-19. Thereby, primary healthcare essentially contributes to reducing the saturation and eventual collapse of healthcare, particularly hospitals. As contemporary primary healthcare services were not designed to cope with a pandemic such as COVID-19, very quick organizational adaptation was required at the beginning of the epidemics to make the best use of limited resources. So separate care pathways for COVID and non-COVID patients are ensured through organizing physically separated outpatient COVID clinics where all patients with respiratory symptoms are examined by primary physicians, either family medicine specialists or pediatricians for children and adolescents. Such organization facilitates the most efficient use of healthcare human resources and personal protective equipment. Obligatory scheduling of appointment by phone or email is introduced, and personal show-up at clinics is no longer allowed. Then COVID-19 testing points are organized in community health centers, usually as drive-in or designated tent areas. And mobile teams are available also for testing people whose mobility is limited or for testing in elderly homes or work organizations. Another novelty is massive transition to teleconsultations with use of e-prescription, e-referral, e-certification of sick leave, and additional phone lines are dedicated to COVID-19 information. This contributes to ensuring good access and safe in-person consultation for chronic and other non-COVID-19 patients who cannot be managed by teleconsultations. Community health centers also provide health services to ad hoc care facilities for mildly or moderately ill COVID-19 patients who do not need hospitalization but cannot stay at home. This further contributes to reducing the pressure on hospitals. Primary health care is thus a vital part of the national pandemic response, taking care for all mild and moderate COVID-19 patients. This ensures that only severe cases are referred to hospitals, which protects hospital capacities to treat the more severe and critically ill COVID patients. In the graph, the yellowish part shows daily numbers of COVID-19 cases who were treated by primary health care, and only the tiny dark fraction in the middle are hospitalized patients. So you can see what is the burden taken by primary health care compared to what is taken by hospitals. In addition to offering medical care, primary care providers inform patients and their caregivers at home or in other safe housing on how to minimize the spread of the virus and how to care for patients in isolation, and to recognize signs that the illness has progressed to a point where it requires urgent attention. Primary health care providers are also actively reaching out to their COVID-19 patients who are at greater risk. For example, elderly patients who are living alone or other vulnerable individuals. All patients who want to be tested for COVID are accessing the testing through their personal physician, either family physician for adults or pediatrician for children. So they receive counseling on when the testing is meaningful, and also their personal physicians are informed automatically if these persons test positive. While complete epidemiological surveillance system is provided by public health services, primary healthcare contributes to overall public health response by provision of information on protective measures. They consult patients on what are high-risk contacts, when it is meaningful to do the test, how to isolate at home, when they need to react to worsening of disease, or even how to care for family members who got ill while protecting themselves from the virus. But the role of primary healthcare is not limited only to interaction with individual patients. They play a role in strengthening the whole system. Primary care nurses help to educate employees in nursing homes, homes for people with disabilities, and social service providers on how to protect themselves and minimize the risk that they transmit the virus to the people they serve. Primary health care also serves as a source of workforce who help in hospitals and other care settings. So under normal circumstances, primary health care offers a set of comprehensive preventive, promotive, curative, rehabilitative, and palliative services through the life course that help to keep populations healthy and reduce disability and premature mortality. During the epidemics, only some regular services need to be discontinued to reassign the workforce to COVID-19 related tasks. Nevertheless, demand for regular primary care services is reduced as patients tend to avoid health care or postpone their appointments unless really needed. So challenges of quick reorganization of primary healthcare services to respond to COVID are mostly related to financing, where additional new services as COVID clinics, testing, and cost of protective equipment are covered from the state budget. Another challenge is related to national governance of all primary healthcare facilities across the country, as they are under jurisdiction of municipalities. But as with any crisis, there are also opportunities, such as elimination of obligatory sick leave certification for up to 3 days of sick leave, and as is the newly established culture of telehealth consultations, which we hope will remain also after the COVID-19 epidemics will be over. So this is how Slovenia reorganized primary healthcare services to meet the demands of COVID-19 epidemics. Thank you.
Thank you very much, Pia. Very interesting response, and also very proactive, it seems, from the beginning, if I understand the presentation correctly. I would like now to ask Erica to tell us whether we have received questions in our chat box. Erica.
Okay, so people are being a bit shy today, which is, but yes, there have been a couple of questions. Hopefully we've got enough time for 2 rounds of questions. First of all, there's a question on the data. So do we have the data on the increase in cases managed at the community level relative to hospital level? We saw some data in there, but if we talk about that and maybe the comparability of the data. And then there's also a question about the future for telehealth medicine in terms of reaching underserved areas, particularly remote rural areas, and whether that's something that we see as this is going to really sort of like be the boost for that. And if I'm allowed to, I'd like to ask a question myself, which is about do we think there's going to be an iceberg of unmet need? What's in place to actually meet the needs of patients who've delayed going to see their general practitioner during the pandemic? And is there anything around financing, particularly, that we need to bear in mind in social health insurance countries? Sorry, I abused my position there. But yes, and then we'll take another round of questions.
Great. So maybe, Andrea, would you like to start with the data question and whether there is any data available that is good and comparative, and also about the role of treating people in the community in primary care, or was it a particular challenge?
Yeah, I think it's definitely a challenge that we're seeing, especially when we compare data over time, because the conditions have been changing over time. And also the data recording management systems have improved over time. So we need to be really careful when we compare different points in times, because the conditions might have been different, and actually less cases might have been recorded at the beginning. And I think maybe François then can also give the example of the Netherlands in that respect. So it is definitely a challenge, but I would certainly argue, and I put it also in my slides, it's also very much in line with what the OECD found and the EU found in their report, Health at a Glance. We need to have also the data management systems at different governmental levels to be able to record these cases in the future better, so that we actually do not face these challenges in the future. Maybe just a comment on the telehealth in rural areas.
Shall we park the telehealth?
Sorry, sure.
First go to François and then Pia to comment on the data issue, but
Thank you.
Return for the telehealth question. Yes.
Sure.
Yeah.
François, she was already alluding to the Netherlands, so
yes.
Tell us what's going on.
Yeah, what's going on with regard to the data? Well, it's really a challenge to have, let's say, real-time data on this COVID pandemic, especially with regard to the use of healthcare and so on, because well, you need then declarations from GPs who are being administratively processed, etc., etc. So really real-time data are really lacking. So what you then as a second best can use is by having information from samples of GPs, for example, and Nivel is one of the institutes who manages a big database with actual, well, as actual as possible data of the use of GP care. And they issued indeed a number of fact sheets about reduction of consultations and the use of alternative ways, etc., etc. But it's not, let's say, country covering, so it's only based on samples, and only if you really want to have a full picture, it probably takes another year before we will have that.
Yes, and I can also imagine that probably such a system is really vulnerable to localized outbreaks and maybe giving a wrong picture. I mean, it depends, of course, on
the size. Yeah. Well, yeah, that's true.
There are intelligence there, but it's at least an alternative. So
yeah,
in Slovenia, what is the situation there in terms of data? Do you have this data in real time?
So at the beginning, in the first wave, when there were limited testing capacities, we were not testing all cases. So the very obvious clinical cases with respiratory disease were automatically regarded as COVID, and we did not have possibility to acknowledge all those cases. While in the second wave, we have good access to testing, and actually every patient with even milder symptoms and even many asymptomatic people are tested and they are all reported. So we have now very good data both for primary care and of course also for hospital and separately for ICU units. We also have data on, we have very many data, epidemiologic data on cases, especially about those who got infected in elderly homes as a hotspot areas, and also about the people, healthcare providers who got affected. The data on usual primary care services is also being collected, but it is not really real time. We have some like per month data available, and it shows that the usual primary care services have been reduced considerably, even though the telehealth services rose very much. So we are actually observing much reduced access to primary healthcare.
Okay. That leads nicely also to the telehealth question, which I think is very relevant too. So why did it now all of a sudden change, and was it used and wasn't it used before? And also the overarching question, will it stay this way? So Andrea, what is your impression? And maybe Pia or Francois can also react to it.
Yeah, I think it's very contextual in different countries, because we've seen that in some countries they were much better prepared than others in dealing with it. Slovenia had already had reimbursement mechanisms before the crisis hit. Other countries like Austria have been quite slow in responding to that and have been also quite hesitant in taking it up. So I do think that there are a lot of differences. Whether or not it will stay, I think it's quite likely that it stays. I would still have maybe some hesitation still, because I think we will also need to consider whether telehealth, and it has been mentioned also in the chat, will still be able to reach the most vulnerable groups in general. So we shouldn't also see it as a kind of one-size-fits-all solution to implement digital solutions and telehealth solution, because it usually requires some competency in terms of digital health literacy. Yeah. So I think it's important to remember that. I'll keep it there.
Point which I will later ask Pia, but first I want to ask Francois, will this change last in the Netherlands?
Yeah. Well, I also wonder because there were already facilities in place in terms of reimbursement and so on. So that was not the problem. Only it was used on a very limited scale so far before the pandemic. Through the pandemic, it got a boost. That's really true, I think. And when you ask GPs, there was a kind of survey done among GPs, and they expected that they would keep on using it, but on a smaller, again, on a more reduced scale. And I think the main point is there that, well, let's say the nature of GP care is really a personal care. And that means that telehealth, telemonitoring, and teleconsultation is only additional and will never replace the basic communication between the patient and the GP. Yeah. That's at least what I consider as a Dutch position. Yeah.
So Pia, maybe really briefly, you could comment on how do we with telehealth can still reach the most vulnerable, or is that impossible? And is something else needed? And then I will go to Erica again.
Because I already mentioned how telehealth works, and we have quite good also in technical terms good e-health systems even before the crisis. But what the COVID brings to us is that we are now introducing more rapidly the telemonitoring of patients, of ill patients with disease who don't need hospitalizations, but are in high risk of quickly deteriorating their condition. And we are now introducing these technologies so people can stay at home and are being monitored by either primary care or hospital physicians. And we are also now finding solutions for financing such services. I'm convinced that in Slovenia, much of the e-health solutions will remain even after the COVID.
Okay, thank you. So, Erica, we will park your iceberg question, which I really like, and I would actually like an answer, but I saw so many questions coming in. Maybe
fortunately, many of them are related to my iceberg question, so that's good.
That's good.
But yes, there's an awful lot coming in around. So, you know, what were people doing in primary care to try and encourage routine care to continue? Were there any particular strategies around that? Were patient registries used in order to encourage people to continue with their routine care? Then we also had a WHO colleague asking, you know, do we know which conditions were not presenting? So have we got any idea of who was not actually coming forward for sort of the routine care? Then we've also got some really interesting questions on how ready were countries for the rolling out of telehealth initiatives. What was the role of nurses in primary care in the response, not just general practitioners or primary care doctors? And is there any way we can, one of the things we can take forward from this is reducing the administrative burden on general practitioners, particularly around data collection. So what is there anything we can take forward on that? And also, was there any difference in organizational models? So was there a difference between group practices, single practices, multi-professional teams in the way that they responded and how effective that was?
Well, these are really good questions, all of them really good. So what I will do is this, I will go again to Andrea and Francois and Pia, and you can pick a question that you would like to discuss. Okay? So Andrea, maybe is there something you would like to comment on?
It's the dream of each panelist, you know?
Yes.
Yeah. Thank you so much for all the interesting questions that have come up. Yeah, I think the question of who was not coming forward and the following up of the chronically ill patients that were kind of lost along the way. I really liked the example of France that showed that basically the patients that were registered with a GP, that they proactively reached out. So, for example, at a certain age level, 70 plus, but also people with specific conditions, that they were really at a local level. The GP has the overview, knows the patients, knows who might be a vulnerable person, and actually proactively reaches out. I think if we manage to continue with that would be really a big benefit also for after the crisis. And I think again, this is a strong argument for strong primary care in general, because the countries that have these preconditions where there is trust in the GP, where there is a local community that the GP knows, in these countries, GPs will be in a much better position to actually follow up on the patients that would otherwise be lost. Yeah, I think I'll leave it there and give the others also the chance.
We have to be quick. We have to wrap up soon. So, Francois, what is your question?
Well, maybe I'll go a little bit further on that. How were people stimulated to just keep on using care during the COVID-19? And in the Netherlands, at least, there was really a campaign even on television that if it's necessary, just contact your GP. Don't be afraid, because the reluctance was much more among patients than among doctors. And patients thought that the doctors were very busy with COVID and that they would contract COVID if they would go to the practice. And so there was a lot of reluctance, especially among the patients themselves. And so really a campaign in newspapers and televisions was issued to, to give trust to patients that it was safe to use the regular care because everything was arranged well. And with regard to the question, who did not show up in this period, I already mentioned that the chronic disease management programs were suspended for some time, and also the cancer screening programs. There have been already calculations on what the negative effects of that will be, but it's still speculative, I must say. So I don't have really the figures there.
Thank you, François. Pia, what is your question of choice?
So I will pick the advantages of group practices, because I think this is very, very specific for Slovenia. So our community health centers that offer many different services and that where group practices offer their care have shown advantage of being prone for very quick organizational adaptation to the new needs. And also what I must say contributed to this quick participation is that they are all publicly owned. So there were no questions whether they will engage in COVID response or not. All the public health facilities, of course, did contribute from the very start, and we worked really closely with all of them in guiding how they should do that. So in this crisis, these community health centers with multiple practices and publicly owned really were shown as an advantage to the healthcare system.
Thank you, Pia. Maybe you can really quickly comment on the iceberg question. Do you expect like a big catch-up of services and people after?
So actually, after the first wave, the hospitals really did lots of work to catch up for the first wave, and came back to the very good levels of the amount of services. But of course, we are observing already advanced stages of some diseases that otherwise didn't happen. Not only cancer, I mean the cancer programs, state cancer programs, they continue to perform their services, but still we do observe some cancer patients in later stages. And we are now analyzing data on other diseases, but yes, of course, the epidemics will contribute to an iceberg of patients with advanced diseases that we wouldn't see otherwise.
Okay, so that's a little bit of a sad note to end this seminar. I'm trying to wrap it up now, which is really difficult because we talked about so many different things. I think for me, what stands out is that the message also that Andrea was talking about, that we need a sort of a holistic approach. We cannot see GP care, primary care, separate from hospital care. We even heard now also from François, there was actually capacity in primary care that was in some cases not used. So that is an important lesson for the current wave we're in and maybe for a future crisis. I also think that you established really nicely that a strong primary care system does really attribute to resilience of the system as a whole, and primary care plays a key role in this. And I think that the changes that we've been seeing in telehealth and new innovations are worth retaining. And there's an interesting parallel with the hospitals, where also COVID had a catalyzing effect on all kinds of telehealth opportunities that were untapped before. So let's hope and monitor that these changes will last. I'll leave it with that. I will only say that keep your eyes peeled for the special issue of health policy, hopefully somewhere early next year, with Andrea's paper and the team's paper as well. Also, please join us next week, because then we have a seminar on the Visegrad countries and their response, and that is going to be very interesting as well. Plus, I told you that there would be a bonus seminar in 2 weeks from now, same day, same time, and that will be about long-term care, which is obviously also incredibly important and has been a big topic and challenge currently. Also, if you leave, you will see a pop-up where we will ask you to fill out an evaluation. Please do. It really helps us and helps us to improve this series. So thank you for now and hope to see you next week. Goodbye.